Dr. Kuyum is an assistant professor of clinical obstetrics and gynecology at Louisiana State University Health Shreveport. She spent much of her childhood in her parents' rural family medicine clinic and would follow her father on his hospital rounds. Accordingly, she understands the importance of being well informed and prepared healthcare providers in the community. She is going to discuss the evaluation and management of postpartum hemorrhage, which is the leading cause of maternal morbidity in the United States. A link to a copy of her presentation is being put in the chat. We understand that you're not able to copy those links, and we will be sending those links in the follow-up email that will talk about the videos as well. Dr. Kuhn, it's all yours.
Thank you for that introduction. I'm Dr. Maya Kuyum, as she said, Assistant Clinical Professor of OBGYN at Louisiana State University Health Shreveport. I'm going to be talking about postpartum hemorrhage. I have no financial disclosures. The objectives of this presentation are to define the term postpartum hemorrhage, learn the most common etiologies of postpartum hemorrhage, recognize the risk factors of postpartum hemorrhage, understand how to prevent postpartum hemorrhage, and know the management techniques for postpartum hemorrhage. So we're going to start off this presentation by looking at some practice questions, and then we'll kind of go back at the end and answer them. So these were independently created by me. The first one is a 30-year-old female at 40 weeks gestation in her 5th pregnancy presents to a rural emergency department and gives birth within 30 minutes of arrival. You note brisk vaginal bleeding after the placenta delivers spontaneously. There are no genital lacerations. The uterus feels boggy on bimanual exam. You empty your bladder, manually evacuate intrauterine clots, and perform uterine massage. The bleeding continues. Estimated blood loss is 250 milliliters. Vital signs are normal. In addition to initiating intravenous access and fluid resuscitation, what is the next best step in management? Number 2, a 28-year-old female has delivered a term newborn vaginally. You administer fundal massage and apply cord traction to assist in delivery of the placenta. The patient starts experiencing heavy vaginal bleeding suddenly. You see a round mass bulging out of the vagina and can no longer palpate the uterine fundus on abdominal exam. Which of the following pharmaceutical agents could facilitate initial management of this condition? And 3, emergency medical services personnel transport an 18-year-old female who just delivered a 9-pound, 5-ounce newborn at home to the local hospital. You are on call and perform an initial assessment on the patient. Your exam is remarkable for a 4 by 3 centimeter vulvar hematoma. After several hours of observation, the hematoma has not expanded. Vital signs are stable. A complete blood count reveals mild anemia, but is otherwise within normal limits. What is the best next step in management? So let's talk about postpartum hemorrhage. First of all, what is postpartum hemorrhage? It's cumulative blood loss of at least 1,000 mils. There was an older definition that kind of defined vaginal as 500 and C-section as 1,000, but that terminology is out of date now. It can also be blood loss with signs or symptoms of hypovolemia within 24 hours after delivery. And particularly if you have tachycardia or otherwise an increased heart rate and hypotension, which is low blood pressure, you should be concerned for considerable blood loss, potentially 25% of the total blood volume, which is 1,500 milliliters. This is also, like, why do we care about postpartum hemorrhage? Well, it's the leading cause of maternal mortality worldwide. Also, it's the leading cause of maternal morbidity in the United States. And early recognition of postpartum hemorrhage is going to improve your outcomes. So what's the etiology? Well, you can categorize postpartum hemorrhage into 2 categories. One is primary, which is when it occurs within the first 24 hours after delivery. Secondary is when it occurs more than 24 hours after delivery and up to 12 weeks postpartum. Primary can be divided into different causes. One is uterine atony. So essentially the tone of the uterus is relaxed. Laceration, so cuts. Retained placenta. Abnormally adherent placenta. Coagulation defects, and uterine inversion, which is when the uterus actually turns inside out. An example of a primary coagulation defect is going to be something like disseminated intravascular coagulation. Secondary causes are going to include subinvolution of the placental site, retained products of conception, infection, and inherited coagulation defects. And an example of that is going to be von Willebrand factor deficiency. So a way we kind of think about postpartum hemorrhage causes is the 4T's mnemonic device, which refers to tone, trauma, tissue, and thrombin. So tone is going to be the uterine atony that I mentioned. Trauma is going to be the lacerations, expanding hematomas, uterine rupture. Tissue is going to refer to retained placental tissue, and thrombin is going to refer to those coagulation defects. So first of all, what are risk factors focusing on tone? Well, uterine atony can be caused by prolonged oxytocin use. It can be caused by high parity, which means they've been pregnant a few times or delivered a few times. Chorioamnionitis, which is an infection of the inside of the uterus, and general anesthesia. Uterine overdistension can be caused by multiple gestations, so that means like twins, triplets, things like that. Polyhydramnios, that means too much amniotic fluid, which can be associated with things like gestational diabetes and pre-gestational diabetes. Macrosomia, which means that the baby is too big. Uterine fibroids, uterine inversion, which can be caused by excessive umbilical cord traction. So you're pulling too hard on the umbilical cord, short umbilical cord, or fundal placenta, like the placenta is implanted to the top of the uterus. Risk factors having to do with trauma. Well, the problems would be episiotomy, which is when you actually make a laceration yourself to create more room, genital lacerations, or uterine rupture. The risk factors for this would be operative vaginal delivery. That's when you assist the delivery with the device, such as a vacuum or forceps, a precipitous delivery, which means you deliver quickly, or a prior uterine surgery. Risk factors having to do with tissue. Well, your problems are retained placenta and placenta accreta, which is when the placenta is not just implanted on the lining of the uterus, it's actually embedded further into the muscle or the surface of the uterus, or even to organs outside of the uterus. Risk factors for that is going to be something called a sexcentriate placenta, which means that it's got an accessory lobe that's not connected to the main placenta, or prior uterine surgery, incomplete placenta delivery. Risk factors focusing on thrombin is going to be, the problems are going to be preeclampsia, inherited coagulopathy, infection, amniotic fluid embolism, excessive crystalloid administration, so like giving too much, normal saline, things like that. Anticoagulation. Risk factors are going to be abnormal bruising, petechia, fetal death, placental abruption, which is when the placenta detaches from the uterus, fever, sepsis, hemorrhage, and venous thromboembolism. So that's like a clot in the leg, clot in the lungs, things like that. Prevention. So really the only way that's been shown to potentially help with preventing postpartum hemorrhage is to actively manage the third stage of labor. And the third stage of labor is from delivery of the fetus to delivery of the placenta. And the only evidence-based method of prevention is actually oxytocin administration. But most people also say that you should do uterine massage and umbilical cord traction, but not excessive umbilical cord traction. So now we'll talk about management. So first of all, you're going to perform a physical exam to determine the etiology. And then talking about the different etiologies, uterine atony is the most common cause of postpartum hemorrhage, 70-80%. And they showed that like the rate is actually increasing over time. On exam, you're going to feel a soft, poorly contracted, boggy uterus. I usually describe it as sort of a balloon that's only been half filled, is sort of what it feels like. Initial management is you're going to empty the bladder, because a full bladder will keep that uterus from contracting down. Perform a bimanual exam and manual evacuation of interuterine clots. That's when you actually take your hand, insert it into the uterus, and take out the clots that are inside the uterus, as well as uterine massage. So if you're in a situation where you're not in like a tertiary hospital setting or not at a hospital setting at all, and you encounter this, you can at least get this initial management started. You know, you can empty the bladder, do the exam, evacuate the clots, and do the uterine massage. And then if you don't have anything else available, hopefully that'll at least maybe resolve the problem or at least relieve it until you can get help. In terms of medical management, you're going to use a first-line uterotonic agent. Most people tend to use oxytocin, and then about 3 to 25% of these cases will require a second-line uterotonic agent. And so now we're going to go into the different uterotonic agents, because you really want to know off the top of your head when you're in an emergency situation what you can use. So first, there's going to be oxytocin, also called Pitocin. The IV form is 10 to 40 units per 500 to 1,000 mils of, normal saline or lactate or whatever you're using. We usually use normal saline. If you're in an emergency situation, you probably don't have time to, especially in like somewhere where you don't deal with this a lot, you probably don't have time to mess with the IV formulation. So then I would just say get the 10 units intramuscular. It's going to be easier. If you're doing the IV, the frequency is continuous. If someone's allergic to oxytocin, obviously don't give it to them. And then the adverse effects that you can get from oxytocin are nausea, vomiting, hyponatremia, but that's if you've been using it for a while. And then you don't want to give it as an IV push because that can cause hypotension. All right, so the next one is methylorgonavine or Methergin. So you give this 0.2 milligrams intramuscular. You can give it every 2 to 4 hours. Contraindications, the big one is going to be hypertension. You do not want to give this to someone if they're hypertensive because it can severely raise their blood pressure and then you put them in danger of things like a stroke. Preeclampsia, same idea. Cardiovascular disease, and of course, if they're allergic to the medication. They can also have nausea and vomiting from this. And as I talked about, it can cause hypertension. So you definitely don't want to give it IV. The next one is 15-methylprostaglandin F2 alpha, otherwise known as Hemabate. It is given intramuscular or intramyometrial at 0.25 milligrams. Intramyometrial means like if you're doing a C-section and you notice a hemorrhage, then you can actually inject the Hemabate straight into the muscle of the uterus. You can give this every 15 to 90 minutes for a maximum of 8 doses. The big contraindication with this one is asthma because it can have an adverse effect of bronchospasm. Active hepatic pulmonary and cardiovascular disease. It can cause nausea, vomiting. The big one with this is it can cause diarrhea. So at least at our facility, we always give people antidiarrheal medications if we give them Hemabate. It can also cause a transient fever, headache, chills, and I already talked about the bronchospasm. Then there's misoprostol. It's also called Cytotec. You can give this oral, sublingually, or rectal 600 to 1,000 micrograms one time. Obviously, if the patient's allergic, you don't want to give this to them. It can cause nausea, vomiting, diarrhea, shivering. The fever is the big thing. It often does cause that transient fever, and you just want to be aware because sometimes people will think, oh, they have an infection. Well, no, it was the Cytotec. Also headache. So let's say that you try the medical management and it doesn't work and now you got to move to your next step. That's going to be, I'm sorry, I just realized this is down here. Okay. That's going to be your tamponade techniques. So I have a picture here of manual compression. So like if you're somewhere where you don't have the resources for anything else, you can always put your hands in there and manually compress that uterus until you can get some help. Intrauterine balloon. If you're not familiar with intrauterine balloons, then you probably don't want to be messing with them in an emergency situation. This is really for people who know how to use one. But the Bakri is inflated with 300 to 500 mils of saline. The Ebb is actually a double balloon that fills up to 750 mils for the uterine balloon and then 300 mils for the vaginal balloon. You can use a Foley. You can actually do more than one and fill them each to 60 mils. If you do manual compression and you're in a low resource setting, then intrauterine packing is a good option in those cases. You just take some ring forceps, take the 4-inch gauze. Usually you want it to be like a continuous one so that you don't lose pieces of gauze in the uterus. And you want to soak it in 5,000 units of thrombin mixed with 5 mils of normal saline. If other things you can do if you fail medical management is you can talk to, if you have interventional radiology available, you can talk to them about doing a uterine artery embolization. And if you don't have that and you have a surgeon available, you can do surgical management. You can do uterine compression sutures, which is otherwise known as like a B-Lynch suture, which is like a harness around the uterus. You can do vascular ligation, just cut off the blood supply for the uterus, and then you can also do a hysterectomy. So let's say you have uterine atony due to a uterine inversion. So a uterine inversion is when the uterus descends to or through the cervix. And the risk factors for this are going to be a prior uterine inversion. Diagnosis is going to be, you're going to feel you're going to see a firm mass at or below the cervix, and you're not going to be able to feel the uterus when you do an abdominal exam. So for a uterine inversion, the initial management is like you're going to leave the placenta in place. You're going to try to manually replace the uterus. So what that involves is the fundus has dropped to the cervix. So you're going to take the palm of your hand or a closed fist, and you're going to push it against that fundus, and then try to push pressure up until you replace the uterus where it was before. Now, if you look in the literature, everyone says that you need to leave the placenta in situ. The doctors that I've talked to who've done this before, all of them said they were not able to do that because the placenta was big and they felt like they couldn't push the placenta back in. So it is recommended that you leave the placenta in place to prevent further hemorrhage. And so that should be your first line, is to leave the placenta in place and try to replace it with the placenta in place, but like always be adaptable in these situations. Also, you can use uterine relaxation, and the options are going to be terbutaline, magnesium sulfate, halogenated general anesthetics, and nitroglycerin. It's also good to know what kind of dosage you're expecting off the top of your head in these situations. So for terbutaline, you're going to use a 0.25 milligram IV or sub-Q. We usually use sub-Q. Magnesium sulfate, 4 to 6 grams over 15 to 20 minutes. So halogenated general anesthetics, you're probably going to defer to your anesthesia colleagues. But for nitroglycerin, it's going to be 50 micrograms, and you can give up to 4 additional doses of the nitroglycerin if you need to. For refractory management, you're going to want to do something surgical. And I'm not going to go into the details of the Huntington and Haltane procedure because I think that's beyond the scope of this. But those are the two main types of procedures. If you have issues with recurrence, you can put an intrauterine tamponade balloon like we discussed earlier, or uterine compression sutures. Now moving on to obstetric trauma. One type is a genital tract lacerations. That's actually the most common type. You want to rapidly identify anything that could be a cervical laceration or involve arterial bleeding, or if it's really high in the vagina. The first time I saw a cervical laceration, it was bleeding very heavily, very briskly, and we were having to give blood while we were repairing the laceration. So these can be very serious, and you really need to keep on top of it. If you need to move someone to like a better lighting, a better operating space to get it done, then definitely consider that. You can call interventional radiology if you have that resource, or surgery if you're suspecting that the uterine artery got lacerated. Okay, next type of obstetric trauma is genital tract hematomas. So you're going to suspect these if you have a quick delivery that is uncontrolled, or an operative vaginal delivery, which again is when you use a device such as vacuum or forceps to assist with delivery. The only symptoms may be just pain and vital sign deterioration, so you really have to be on the lookout. Most of the time, you can just observe hematomas. If they start enlarging, especially rapidly, then that's when you're going to want to do surgical expiration and potentially arterial embolization. The reason, if it's not enlarging, the reason that you don't generally do surgical expiration is because typically when you go in there, most of the bleeding is coming from venous sources, and so it's pretty difficult to control. So it's just better to observe them if they're not enlarging. Vital sign deterioration without visible bleeding, you should suspect that you've got bleeding in the abdomen or retroperitoneal. And if that's the case, then you need to don't delay resuscitative measures. You need to get some diagnostic imaging like a CT. You need to get surgery or interventional radiology on board pretty quickly. The next type of obstetric trauma is going to be a uterine rupture. So the risk factors for this are going to be a prior surgery involving the uterine wall, like a cesarean delivery or a myomectomy, which is removal of a fibroid. And that's because whenever you do surgery on tissue, obviously the scar that forms afterward is not going to be as strong. And now you're potentially contracting on a part of the uterus that's weaker than it should be. Also, congenital malformations like a small uterine horn, abnormal labor. The management in this situation is going to be repair of the rupture. So next type is going to be retained placenta. Every time you do a delivery, you should inspect the placenta to make sure that it delivered intact. Risk factors for retained placenta is going to be manual removal of the placenta or prior uterine surgery. You can diagnose this with ultrasound. You'll see an echogenic mass in the uterus. Also, if you physically manually put your hand in the uterus, you may feel the retained placenta. The management for this is to remove the retained placenta. You can use something called a banjo curette, which is essentially just a curette with a large oval. And you can use ultrasound guidance to decrease perforation risk, but you don't have to. If you are suspecting placenta accreta, again, that's when the placenta implanted, not just in the lining, but went into the muscle or something further, then most of the time you'll do a hysterectomy. There are these select cases where you can do conservative management, but that's also, I feel, beyond the scope of this. So then the next type is acute coagulopathy, and one type is placental abruption. So a placental abruption, again, is when the placenta separates from the uterus. A cuvullary uterus is when blood has moved into the muscle of the uterus, and that can cause atony. Other complications are going to be disseminated intravascular coagulation and low fibrinogen. The classic triad for placental abruption is bleeding, tachysystole, which is frequent contractions, and pain. But there is some such thing as a concealed abruption where you don't see the bleeding. The classic contraction pattern is going to be the contractions are going to be not very powerful, but they're going to happen close together. And this makes up 17% of massive transfusion cases. So it's a big deal. Right. Another type of acute coagulopathy is amniotic fluid embolism. Definitely don't wish this on anybody. This is rare, unpredictable, unpreventable, and a devastating emergency. The classic triad is going to be hemodynamic compromise, respiratory compromise, and disseminated intravascular coagulation. Management is going to be aggressive volume replacement, and you're going to want to start your massive transfusion protocol if you're suspecting this. So this doesn't really have to do with the cause of postpartum hemorrhage. Tranexamic acid it's been shown to reduce mortality from obstetric hemorrhage, especially if you use it earlier within 3 hours of delivery. So most, at least at our facility, if you're having a postpartum hemorrhage situation, most people are going to go ahead and administer the tranexamic acid just because of that reduced mortality rate. Unless, of course, there's a contraindication to it. So secondary hemorrhage, again, this occurs more than 24 hours after delivery and up to 12 weeks postpartum. It can be caused by retained products of conception, which again, you can diagnose by ultrasound and you manage by removing the retained products of conception, otherwise known as curettage. Also, endometritis can cause this. So Endometritis is an infection of essentially lining of the uterus. And this is diagnosed by uterine tenderness and fever. You manage it with antibiotics, classically clindamycin and gentamicin. But if someone's screened positive for group B strep colonization in the pregnancy, then you would also want to add the ampicillin. Okay, so massive transfusion protocol. So this is defined as greater than 10 units of packed red blood cells within 24 hours, or 4 units of packed red blood cells within an hour, and ongoing need for blood is anticipated, or replacement of the patient's complete blood volume. Again, kind of going back to the beginning of the lecture, if you've got someone who's got tachycardia and hypotension, there's a good chance they've lost, about 1,500 mils or 25% of their blood volume. So in that case, you really should go ahead and prepare for a mass transfusion situation. The recommended ratio is 1 to 1 to 1 for packed red blood cells to fresh frozen plasma to platelets. In the real world, that's a difficult ratio to achieve because usually platelets are expensive and not easy to obtain. All right, so let's wrap back around to the practice questions that I mentioned at the beginning, and we'll take a few minutes to answer these. So again, number 1 is going to be a 30-year-old female at 40 weeks gestation in her 5th pregnancy, presents to a rural emergency department and gives birth within 30 minutes of arrival. You note brisk vaginal bleeding after the placenta delivers spontaneously. There are no genital lacerations. The uterus feels boggy on bimanual exam. You empty her bladder, manually evacuate intrauterine clots, and perform uterine massage. The bleeding continues. Estimated blood loss is 250 mils. Vital signs are normal. In addition to initiating intravenous access and fluid resuscitation, what is the next best step in management? The options are A, oxytocin administration, B, methogen administration, C, intrauterine balloon placement, D, uterine artery embolization. So I'll just give everyone like a minute to think on that before I tell you the answer. All right. So the answer is A. We're in a situation here where someone is having a lot of bleeding, and the placenta has delivered spontaneously. You don't see any lacerations when you do your physical exam. You do feel like the uterus feels boggy. You do all your conservative measures. So you empty her bladder, you evacuate the intrauterine clots, you perform the uterine massage, and her vital signs are normal. You start your IV access, you start your fluid resuscitation. So you're now looking at medical management. And so that's why you're going to start your oxytocin administration. All right. Number 2, a 28-year-old female has delivered a term, that's the second time I did that, a term newborn vaginally. You administer fundal massage and apply cord traction to assist in delivery of the placenta. The patient starts experiencing heavy vaginal bleeding suddenly. You see a round mass bulging out of the vagina and can no longer palpate the uterine fundus on abdominal exam. Which of the following pharmaceutical agents could facilitate initial management of this condition? So I'll just give you guys a little bit to answer that one.
We do have some answers rolling in, but I'm not going to tell you this time until more people have contributed. I probably blew it the last time.
I'm sure people had gotten it by the time you said anything. All right. So what are people saying?
Most people are saying D.
Yes. Oh. Correct. Okay. So in this situation, you have, you're trying to prevent your postpartum hemorrhage by like actively managing your 3rd stage of labor. You're doing the massage, you're doing the cord traction. But now you see heavy bleeding suddenly, and then you see this round mass bulging out of the vagina. And when you try to, palpate the uterus abdominally, you can't feel it anymore. So this is likely a uterine inversion situation. And so it's asking like what particularly pharmaceutical agents could you use to help. And what you're going to try to do is you're going to try to manually replace the uterus. And what's going to help you manually replace the uterus is giving something to relax the uterus. And all of these are options. And then, of course, there's another option, which is the halogenated general anesthetics. All right, last one. Emergency medical services personnel transport an 18-year-old female who delivered a 9-pound, 5-ounce newborn at home to the local hospital. You are on call and perform an initial assessment on the patient. Your exam is remarkable for a 4 by 3 centimeter vulvar hematoma. After several hours of observation, the hematoma has not expanded. Vital signs are stable. A complete blood count reveals mild anemia, but is otherwise within normal limits. What is the best next step in management? So your options are observation, drainage of the hematoma, embolization of the vessels, or surgical expiration. I'll just give people about 40 seconds to think about that. All right. What is everyone saying?
Everyone's saying A.
That is correct. So this patient had like a pretty large baby at home, and now she's got a hematoma, but you're observing it and it's not expanding. Her vital signs are stable. So in these cases, you can observe the hematoma. Okay, so these are my references. And thank you to everyone for inviting me to participate in this symposium. I hope that this provided like practical knowledge on, if you're a community provider and you come across someone who's having a postpartum hemorrhage, like what kind of resources do you have? And really the important thing is if you have these medications available, you should know your dosages off the top of your head if you can, because when you're in an emergency situation, you don't want to be thinking like, oh, how much nitroglycerin do I need to give? How much oxytocin do I need to give? You really want to be comfortable with that. Okay.
All right. We have a couple of questions. All righty. And I believe about 5.
Okay.
But I'm going to try and condense those because some of them are regarding the same thing.
Okay.
So first question is, how effective is the JADA system?
The what?
The JADA system, JADA.
I don't know, because I've never heard of that.
Well, there was another question regarding the same system. Have you had experience with the new JADA device for postpartum hemorrhage management?
Oh, okay. I gotcha. No, I have not used the JADA device. Okay. Now I know what they're talking about. No, I have not used the JADA system.
Okay. Next question that we have, would you consider TXA for postpartum hemorrhage IV or as intrauterine packing?
For tranexamic acid?
Yes.
Oh, sorry. I should have gone into detail about that. So typically we give 1 gram IV.
Okay.
In a hemorrhage situation, a lot of people have started using it prophylactically. So if someone has a history of putting, the data on here is going to probably come out soon, hopefully, but a lot of people have started using it prophylactically. So if someone has a history of postpartum hemorrhage, they'll just go ahead and give them tranexamic acid.
Okay. Now, something else to do with tranexamic acid, what are the contraindications for it?
Oh, good question. So really it's going to be like the real absolute contraindications are going to be active thromboembolic disease. But if someone has a history of thromboembolic disease, that's also, so this is kind of controversial. So if you look it up in like your micromedics or, your hospital system, it's going to say that a history of thromboembolic disease is also a contraindication. But if you look at your American College of Obstetrics and Gynecology information, especially even outside the non-pregnant situation, they have they have this, I think it's a committee opinion on how to manage acute vaginal bleeding in non-pregnant patients. And when they list the tranexamic acid, they actually don't list a history of thromboembolic disease as an absolute contraindication. So I would say that like non-OBGYNs probably won't give it to someone who has a history of like a clot before, but there are some like gynecologists who potentially would in like a non-pregnant situation, acute bleeding situation. But definitely if you have active thromboembolic disease, you're not going to want to use it because it is an antifibrinolytic agent that's, you know, messing with people's clotting factors and their coagulation pathway.
Okay. We've got another question. This is recommendations for timing of routine oxytocin administration during or after delivery. Give with delivery of anterior shoulder versus wait until placenta delivered.
Okay, yeah. So at least at our facility, we usually wait until after the placenta delivers, but sometimes if the recommendation for how long you should wait to deliver a placenta is about 30 minutes. And so if if it's taking a longer time than that to deliver the placenta, then a lot of times at our facility, at least we will go ahead and start the oxytocin administration to actually help deliver the placenta.
Okay. Next question is, we were informed that the EBB system is no longer being produced. Is this accurate?
Oh, you know what? I had heard that too, but I actually did not look that up.
Okay.
Yeah, so I have also heard that rumor, but I do not at this time know if that's true or not.
All right. And we've got one more question for you. And that is, how do you get your doctor's attention if you start to feel bad after delivery and blood is in your catheter bag, but no one is paying attention?
Okay. So I guess the question is like, you're trying to get someone's attention and they're not paying attention to you. Is that the situation?
I'm thinking that's the situation.
I mean, I would say that I haven't like personally encountered that because I feel like we're all pretty, when it comes to postpartum hemorrhage, we're really, at least at our facility, we're really on top of that. Like you know, if someone is high risk, we already have like the medications in the room. We have like a kit that's ready to go with everything we need. People are really on high alert for these things. But I would say that like first, obviously you can talk to your nurse. And if your nurse is not able to get the attention of the doctor, then see if you can like personally speak to the physician. And if you feel like, you know, for some reason the physician is not taking your concern seriously, then you can always talk to someone higher up, like in hospital administration. There's usually a house supervisor, someone higher up. There's also usually like a patient sort of, you know, quote unquote complaint department where you can air your grievances. So you just kind of go up that way. But I would say that at least at our facility, like, you know, if someone said they had, you know, blood, if they were concerned about a postpartum hemorrhage, then we would take it pretty seriously, you know.
All right. Awesome. That's the end of the questioning. Thank you.
All right. Thanks.
Thank you, Dr. Curum, for your speaking, and we appreciate it. And we are now way ahead of our schedule, which is always a good thing when you're seeing, and you had lots of positive responses. All of our speakers have had hearts and clapping and other things, responses coming up.